Okay, well, why don't we get started here? Try to finish up the shoulder today. And Sheila already gave us a little talk on frozen shoulder, but let's just go through this again. Uh, and so we'll go through. So we already talked a little bit about the clinical stages. There are four classic clinical stages to frozen shoulder, and we'll go through these again in a minute as well. Classically, it's an insidious onset of shoulder pain and then gradual stiffness. Stage one is usually in the first 3 months. We have pain and limited range of motion. And initially, the range of motion is internal and external rotation. And then abduction comes later. Stage two is between 3 and 9 months. We get progressive limitation of range of motion, and the symptoms may get a little bit better at this time period. And on an MR, you may see thickening of some of the capsular ligaments at that point. Stage three is 9 to 15 months. The pain really starts decreasing substantially in this time period. And then the stage four is 15 to 24 months, and range of motion gets back to being better than before. Most of these patients, the vast majority, are able to be very functional after 2 years and don't really notice any limitations, though more than 50% of people, if you do careful measurement of their range of motion, there is a lasting decrease in the range of motion, but we discussed that a little bit before. And if you do biopsy studies during this time period, in stages 1 to 2 is what you see is increasing degrees of synovitis. There's been a lot of discussion in some of the online stuff recently about radiologists distending the joint space with contrast, whether you should distend it enough where you extravasate contrast through a rupture of the capsule or not. Most of the information that I've heard recently in the orthopedic literature suggests that overstretching the capsule actually makes the inflammatory changes worse and leads to a worse outcome. So most people in the orthopedic field I know right now don't recommend doing aggressive stretching. It should be passive stretching, especially in stages 1 and 2. And I think the radiologist distending it by arthrography is more, it's done a lot these days, but I think it's really should be more of a historical type treatment at the current time. And there's also a discussion about the use of steroids. Steroids have been shown, intra-articular steroids have been shown in some papers to have a short-term improvement in symptoms, but no long-term improvement in the actual course of these patients. So it's now become more controversial as to whether or not steroids should be used. John?
I don't think if you suspect a frozen shoulder, I don't think you should stick a needle in it for any reason. It's just gentle observation and neglect with some intelligence. Leave the patient alone, let them exercise on their own, and gently get the range of motion and reassurance. So what I would do, and I haven't seen one for a while, I would see the patient on a regular basis and say hello, how are you doing, and many times you need tranquilizers and so on, and pain medication for these folks. So
It's very much debated as to what initiates it. Some people believe that any trauma to the shoulder, if you immobilize the shoulder, increases the risk for frozen shoulder. It's very highly associated with diabetes mellitus, and it's very highly associated with people over the age of 40. When you biopsy it, it is inflammatory. They're true inflammatory cells, and it is true. If you call it capsulitis, you're right this time, if you use the itis word. So it is true. But non-steroidals, and as I said, injections of steroids haven't really been shown to change the overall course of the disease, though they may help the symptoms. So they're often used more for symptom relief. I don't know of any studies that have used true anti-inflammatory drugs in treating this condition.
What do you mean by true anti-inflammatory?
True anti-inflammatory, I mean that TNF-alpha inhibitor or other inhibitors of the complement cascade, which would be considered disease-modifying anti-rheumatic drugs.
I had a pretty significant case of this. I was pretty much self-diagnosed, but I don't think normally they biopsy him. But yeah, it was pretty painful. It was extremely painful, and I just couldn't figure out where the heck it was coming from. And yeah, I did put some steroids in there, like injected, distended, not myself, but yeah, I mean, it made a big difference. I mean, I was having a lot of pain, and I tried to do the physical therapy, which it's impossible to do when you're that frozen and that painful, in my shoulder, yeah, right here.
That's very hard to believe that at your age you've had that. That's extremely, extremely rare. You
Is
see
it?
this in 50-year-old women, mostly menopausal gals.
I mean, I
And you
can't
don't
think of
look
what
like
else
that
it would
at
be.
all.
But the steroids, yeah, I mean, they immediately took the edge off of it, and it,
Well, you had an inflammatory process. You strained your biceps tendon or maybe a rotator cuff injury or whatever, but you certainly did not have a frozen shoulder.
How long did it take you to get over?
I mean, I'm not 100%. I'm probably 90% back in terms of like pain and range of motion. I mean, it doesn't inhibit me in any way, but I mean, it was quite a few months. It was it came on insidiously, and then it just kind of,
Stand up for a second.
Yeah, if it's just a few months, that would be unusual for the time course. Usually it's 2 years, but it could be. Okay. Oh, why don't we go ahead here? Okay, Dr. Yagutis is giving a raw physical exam here. Yeah. Okay.
Frozen shoulder as much as I.
Okay.
the process took about a year before it kind of got to the point that.
Okay. Could be.
Dr. Cruz,
Yes.
who typically does these procedures? Are these done by the distension? If they are done, is it typically done by a radiologist or is it done by orthopods?
Well, it can be done by either, but in my training program, it was done by the radiologists. And I've worked in some locations when I was in Santa Barbara. There's an orthopedic surgeon there who did it. So it can be either. Typically, I would say if it's done in this day and age, it's generally done by the radiologist. And if our one case a day, where there are about 300 musculoskeletal radiologists around the world that get together and share cases online on a daily basis. This has been a recent topic, and it sounds like there are a lot of musculoskeletal radiologists who do this on a routine basis.
Yeah, I saw that discussion, but it didn't seem like a whole lot of people replied. So I wasn't sure how many people do that in radiology. Okay, thanks.
Generally around here, it's considered contraindicated.
Okay.
Generally to do hydrostatic distension of the joint, though I think there are some people who will put steroids in it, but aggressive management generally is no longer thought to be standard of practice, at least among. We'll get a lecture on this with Curl and Job too, and they'll talk about it and go through all the orthopedic literature.
Okay, thanks.
Okay. Let's see, Michael, what do you think of this case?
Two axial views of the shoulder. See along the medial aspect of the humeral head and the joint capsule, looks like there's increased signal and thickening of the joint capsule there. Yeah. Yeah. So this would capsular edema or thickening. Sure. I think as we talked about before, this is not a specific finding for chronic capsulitis, right?
It's not. This happened to be a patient who had the clinical syndrome, and in the severe cases, the entire capsule can get inflamed. Though generally it's believed right now that almost always it starts and is most severe in the rotator cuff interval, with a prominent involvement of the proximal part of the biceps tendon, and only in occasional cases is it severe enough to involve the entire capsule, which can happen, as we'll see. So this is a really nice paper from Europe, that shows MR findings in a series of patients with clinical evidence of frozen shoulder or adhesive capsulitis. This is the coracohumeral ligament in this diagram. Here, this would be the long head of the biceps tendon, supraspinatus muscle, coracoid process, humeral head, subscapularis. So this is the rotator cuff interval in this area. The tendon that we've all looked at, or the ligament that we've all looked at repeatedly when we've looked at studies together, that you have to look at on every single case in the sagittal plane is the coracohumeral ligament. What actually goes up over here comes underneath the subscapularis muscle and attaches to the humerus over toward the right. And then below that we have the capsule, and in this triangle should just be fat. So one of the early findings that they found in patients who are symptomatic is thickening of the capsule in this location very close to the biceps tendon. On the axial images, and I'll show some of those in a minute, it's generally right in this particular area and through here. And then so you can see several stages. This would be normal, kind of moderate. Now, the term I use for this is scarring or generally scarring in the rotator cuff interval, and it can be moderate or it can be severe, where all of the fat, extracapsular fat there, is replaced from the coracohumeral ligament down to the capsule in that location. And this is from their article showing different stages of the scar replacing the fat within the rotator cuff interval. Probably a major cause of the symptoms here are actually the adhesions to the long head of the biceps tendon. And you can see this finding with ultrasound with thickening in the coracohumeral ligament and replacement of the normal fat. Here's a 51-year-old with limited range of motion from Dr. Su that showed some thickening in that area. This just shows an injection on an arthrogram showing that there's a very small space within the capsule. And in the old days when I was a resident, one of the ways the diagnosis was made was by showing that there was a very small capsule with arthrography. And there are numbers, size of the capsule. I don't think you need those anymore as to what's abnormal or not. Dr. Su went through some of the history, and this has been around for a long time and called a number of different things, from adhesive capsulitis and so forth. Typically, actually, the term I generally use in my reports is I describe the finding and say it's compatible with chronic capsulitis. If it's dark and not bright on the fluid-sensitive images, if it's bright on the fluid-sensitive images, then I describe it and say it's compatible with capsulitis. Most of the time, by the time we get them and they have limited range of motion, it's in one of the stage 2 or 3, often stage 3, and it's more of a chronic capsular thickening rather than an acute capsulitis. The other term for it is frozen shoulder, but this should not be used in a radiology report. This is strictly a clinical description of the shoulder itself. And we've talked about a lot of the symptoms. Clinically, as John said, it's very, very uncommon before the age of 40. It peaks around 56 years, more common in the men than women by far. Different treatments that we've talked about. In very severe cases, and this is generally considered in about 5% of cases, if patients continue to have limitation of range of motion after 2 years, they can go in and do a capsular release, where they basically cut the capsule to allow it to stretch. And then we already talked about the clinical phases that we don't need to go through. Its most common association is with diabetes mellitus, so we might well expect that this may be more common in the future because more people being overweight, at least in the U.S., and that leads to type 2 diabetes, which is highly associated with this particular disease. There are others, as you can see down here, that have also been associated with it, and basically anything that can limit the range of motion of the shoulder, like stroke, has an increased risk of adhesive capsulitis. So, Ron, what do you think of this case?
So it's our sagittal view of the history of frozen shoulder. There is some low signal within the rotator interval, And it almost looks like it's, is that the maybe the coracochromial or the coracohumeral ligament almost seems like retracted by it. Again, I'd probably use the term chronic capsulitis to describe this.
So here you really don't see the margin of the biceps tendon. This is out where we should be seeing the biceps tendon up here, adjacent to the humeral head, and so this is all sucked in scarring in this area. And you can actually see, as you described, it looks like it's even contracted a little bit with a little bit of depression of the coracohumeral ligament.
Coracochromial or coracohumeral.
I changed it to coracohumeral.
Thank you. I just want to keep you guys straight.
Good job, good. Here's the coracochromial ligament, and it looks nice here, what we partial volume. Okay, so there we can see it frozen. On the PDF side images, we can actually see a little bit of high signal intensity in this region on the coronal images. And here we can see replacement of the normal fat, a little bit like that diagram in Mingiardi's paper. And that was chronic capsulitis and the clinical syndrome of adhesive capsulitis. And here we can see much more scar tissue in the region of the triangle, kind of that moderate replacement. There's still a little bit of fat in the rotator cuff interval. So this would be the subcoracoid triangle sign. And again, we don't see a good visualization of the biceps tendon because its margins have been obscured by the scarring from the process. On the axial images, again, we can see all this scar tissue here in the area of the rotator cuff interval with thickening of the capsule. And here's a more severe example. Here we can see a little bit of the biceps tendon here, but now all of the fat has been replaced in the rotator cuff interval due to scarring in this patient who, this is, I think, close to stage 3 or 4 at this point, but was, I think, just beginning to get some limitation of motion back again, but that scar in the rotator cuff interval. So let's see. Sheila, what do you think of this case?
Okay, so here it looks like there's obliteration of the fat kind of in the subcoracoid region adjacent to the biceps tendon and the rotator cuff interval, so I'd be concerned about a chronic process such as adhesive capsulitis. And again, there's that like soft tissue density or low signal intensity in that region.
Yeah. So again, I usually call this compatible with chronic capsulitis. This is more of the dense, more fibrous type nature to it. Okay. Yuri, what do you think of this?
Okay, so a X-ray or spot image of the shoulder demonstrates abnormal contrast. There's decreased amount of contrast within the joint, glenohumeral joint, such that there's questioning. I would question if there's adhesive capsulitis. On the axial CT images, there's on the right side image, there's abnormal, especially on the right side image, there's abnormal soft tissue density within the biceps interval, again suggesting adhesive capsulitis. Also on the oblique coronal views on the MRI, there is increased synovial capsular thickening, again raising possibility of or consistent with chronic capsulitis. On the additional image, there's obliteration of the fat within this region.
Good. So this is a more diffuse form where there's a lot more capsular thickening. In this case, a lot of acute edema in this person with really more of an acute stage of adhesive capsulitis. And then this is really a long-standing chronic stage in a patient who had, this is several years after the initiation of the symptoms, and we can see very severe thickening of capsule diffusely, and this patient had severe limitation of motion and was being evaluated for possible capsular release. This was a few years ago before they were doing these routinely with arthroscopy. And often with these, they would go in and initially try to do manipulate under anesthesia to try to break up the adhesions and so forth. But this was so dense that there was a real risk of fracturing the humerus. So I think they ended up doing an open release of the capsule in this particular case.
They did an open release?
This was before arthroscopy. This was in the early days of arthroscopy. So the person who was doing this wasn't an arthroscopist.
I wouldn't dream of doing an open release on one of these cases. I just wondered, Sheila, what does the synovial membrane look like in these shoulders?
Probably thickened and maybe coarse appearing,
I would think so. I think it's probably fibrotic too, just like the capsule. I think it's an synovial and capsular type of a problem. I don't think it's just a capsule. The synovium is the bad guy in a lot of these diseases.
Yeah, if that's the case, you'd think they would really try to use more aggressive anti-inflammatory drugs. And then here's another case with much more thickening of the capsule with fibrous thickening in someone who had marked limitations of motion. Okay. Yeah, it would be a good study. The problem is that the TNF-alpha inhibitors are so expensive. Well, actually, we could probably get a drug company to fund it, but you could use methotrexate. That's a. I'll have to look into that. Susie, what do you think of this case?
Excuse me. So there's abnormal signal intensity in the humerus and adjacent glenoid with subcortical cysts and bony eburnation. I think the articular cartilage is also denuded there. And then within the axillary pouch, there's I think there maybe is a little bit of synovial thickening. There's some dark signal right there. Yeah. So I'm not quite sure what all that around there is, if that's just part of the capsular adhesions. Well, are we on a theme here? I guess it would be the capsular adhesive capsulitis, but
Okay. Yeah, I don't think this is adhesive capsulitis. This is very severe degenerative disease with subchondral geodes, denudation of the articular cartilage, and very large marginal osteophytes here. And both sides of the joint space is destructed, and this is just severe osteoarthritis. And I don't really believe that osteoarthritis is primarily an inflammatory condition. And all the studies that I know that have tried to treat this with anti-inflammatory drugs have not been successful at changing the course. Though there still are researchers and drug companies in the world who really point to the fact that all of these patients with severe osteoarthritis have inflammatory changes if you look hard enough. And I think they're really looking to try to find something that they can use a drug to treat. But in reality, I think these are all really have to do more with trauma and repetitive trauma rather than inflammation. And I think inflammation is not a significant component of the pathophysiology of the disease, but there are a lot of people who would disagree with that.
Dr. Cruz, real quick, I assume we've left the capsulitis topic and we're moving on to something. So before we leave that, so really focus on the rotator interval. Don't get caught up on what's going on in the axillary pouch when you're looking at adhesive capsulitis. So only use it as a secondary, not even that, because if you with or without it, you're going to call it capsulitis based on what's going on in the interval.
Now, early on in the late 1980s, a couple of early patients we had, in fact, that one with a very thickened black line that John and I were talking about was one from about 1988 that had severe frozen shoulder, but that was long-standing. So we started looking, and one of the orthopedic surgeons I worked with in Santa Barbara was a big interest in this and had patients from all over the country who would fly in there to to get treated for frozen shoulder. And so we looked into it, and some of our early patients who were in the really hot early phases had very thickened capsule in the inferiorly. And so originally that was the criteria we used was really thickening and edema within the inferior capsule. So, and some of the chapters and so forth we wrote, that's what we put in there. But it turns out if you use that, it's very insensitive. Most patients with the clinical syndrome of adhesive capsulitis will never develop those symptoms, or at least we rarely ever catch it at the time we do imaging. Maybe we do the imaging too late or something. I think with Mingiardi's paper, looking at the rotator cuff interval, and other people had looked at the rotator cuff interval before, but he is the first to really have good data showing that that's really the most sensitive area. And if you look primarily in the rotator cuff interval, you have much better sensitivity and specificity for evaluating the disease. And then pathologically, most people have found that arthroscopy now, that's really where the disease has its earliest manifestation and really where it's basically focused. As I said before, occasionally it will become a more generalized condition, but it virtually always involves the rotator cuff interval. So that's the best place to look for it. And if you see it there and a concern, then look at the rest of the capsule, which kind of lets you know whether it's a more generalized process or more localized. Most of them stay pretty localized to the rotator cuff interval in my experience, and I think that's what most other people have found too.
Dr. Cruz?
Yes.
Did you read any of they had a whole discussion on adhesive capsulitis and treatment on the OCAD this past week in terms
Yes.
of do you
Yeah,
send the capsule?
we were talking a little bit about that earlier, Sheila. And
Oh, okay.
generally around here, most people I work with believe that it's contraindicated to do hydrostatic distension of the capsule. That several studies in the orthopedic literature, and I'm sure at one of our Curl and Job lectures will be on adhesive capsulitis, and they'll go back through all the literature. We cover that every year. But there are a number of papers now that have shown that if you increase the trauma, if you overstretch or do any increased trauma in stage 1 and 2, it actually prolongs the disease process and the outcomes are worse. So most of the recommendations now are in stage 1 and 2, you really should minimize any trauma to the capsule. And if you do any stretching, it should be very passive stretching, because there was a time when people were very aggressive at stretching these early on, thinking that if you don't stretch them, and actually there was a time, my sister-in-law had adhesive capsulitis last year, and the surgeon she saw in New York basically sent her and kept getting angry at the physical therapist for not being aggressive enough because she kept losing motion, range of motion of the joint space. But there are several studies out there that show that overly aggressive physical therapy, like he was recommending for her, actually lead to increased inflammation and worse long-term outcomes. So generally it's agreed now that you don't want to overstretch or traumatize the capsule. So that's generally, most people I work with now consider that the hydrostatic dilation, as was talked about in OCAD, is really contraindicated. But again, there's still a wide range of belief in this. And when I was a resident, that's the way they were treated. But right now, at least with the people I usually work with, that would be considered archaic and not a standard of practice right now.
And if you do that, you better get a good lawyer to back you up.
Okay.
So I don't recommend it. Okay. Let's see. Michael, what do you think of this case?
We have two axial views of the shoulder. Humeral head has large osteophytes arising from it anterior and posteriorly. The glenoid subchondral cystic changes, some eburnation as well. So I think there's a severe degenerative disease of the shoulder. Also, posterior labrum, I think, is torn on this image here as well.
Again, this is a degenerative disease, and a lot of names are given for this, and you can use whatever you want or whatever people in the community. You could call this osteoarthritis. I've kind of gone away from use of the term osteoarthritis because, again, I think it's a misnomer. I don't really think it's an inflammatory condition, though there is a component, but it's a minor component. So I generally just use the term degenerative disease, and then obviously you need to describe all the things that Michael described, so that the person reading a report can get a sense for the severity, and also the marked loss of articular cartilage here has to be included in that.
I think if you follow trauma, like in football players and sports in general, repetitive trauma probably flakes off the articular surfaces one way or another. These become kind of like irritants, like putting sand in a joint. And this is the result of what you have over the years of misusing your articular anatomy in your body. Well, now, not everybody gets this problem, obviously.
And you can see this patient actually has very well-developed muscles, so this was probably an overuse syndrome. Okay, Aram?
All right, looks like we got a T1 and T2 weighted image. Once again, there's a denudation of the articular cartilage. There's subchondral eburnation and signal granulation tissue. There's a large, I don't know, 1 or 2 centimeter little signal focus in the, I don't know, that's probably the subcoracoid recess, and which would be suspicious for a foreign body. So degenerative changes with a foreign body, possibly osteochondral lesion.
Yeah, actually, neither of these are T2 weighted image. This is a PD images, and this is a T1 fat sat post-contrast. And once you fat sat it, it's no longer a T2 weighted image again because the contrast is dominated then by the fat sat. So, but we'll talk about that in the physics section. You can see a lot of denudation of the articular cartilage, subchondral cystic changes, meniscal tears, and this isn't a foreign body. This is a loose body, but it's not foreign. It's not foreign. It's inside, and it has a fairly characteristic appearance that you see occasionally. Some people call this the medallion appearance, but actually looks almost like a coin. Some people call it a Roman coin appearance. And when these get very large, you tend to have these kind of cystic areas around the side with the ossification in the center, and that's a loose body.
Now these tend to grow. For some reason they grow in the joint. That they didn't come off that large.
Yeah, well, remember that the articular cartilage gets its nutrition from the joint fluid, and a lot of these to start out as pieces of articular cartilage, and then they grow just like articular cartilage does because they get nutrition from the joint fluid.
And loose bodies have a smooth surface, just like articular surface. And that's why they slip around. They're very, very slippery. You can't hold one in your hand without losing it. And I'll never forget, I was doing a knee that had osteochondromatosis, synovial, and all I got is marbles that were floating all over the place, including the floor. And I'm not kidding, they're bouncing around because they just came gushing out at me. And anyway, I did a synovectomy on a patient. It was kind of interesting. It looked like there's a birth of the small marble, and then it kept growing in different sizes. Like looking at pearls of different sizes.
In the mass section, we'll see some of those MR appearance. Susie, what do you think of this case? Patient with shoulder pain.
So there's a sagittal image that demonstrates abnormal signal intensity within the infraspinatus muscle. The subscap teres and supraspinatus muscle look normal at that level.
Wait. So you say the infraspinatus, what about the supraspinatus?
Well, I'm thinking that it looks normal at that level unless that is a little bit of abnormal signal intensity in the anterior portion. Oh, okay. So I think that this person may have an issue with the nerve, the supraspinatus nerve that gives off branches to these two muscles.
What kind of problem?
There may be some compression on it with a cyst or something like that.
What does this show?
there is a slightly lobulated, where there's abnormal signal intensity within the muscle. And then, yeah, and then if you come to me, yeah, maybe I'm wrong, but I think when you look where you see like two little vessel type structures, is that an abnormal little blob that's down? Yeah, little blob right through there.
I think it's just a normal fascial plane between
Oh,
the teres minor and the infraspinatus.
okay. Then how about if you come down more inferiorly,
Down here?
right there?
Yeah, that's the neurovascular bundle in the
And that's
quadrilateral
normal like
space.
that? Oh, okay.
Quadrangular space.
Quadrangular space. Okay. Again, it just shows abnormal signal intensity within the muscle. That makes me think that's atrophy, maybe nerve damage.
So we don't see any cyst here.
Nope.
So what's causing this?
I'm not sure.
Do you know what the Parsonage-Turner Syndrome is?
I did about 4 weeks ago. I don't remember.
Well, maybe you can kind of look this up and see what the latest is on Parsonage-Turner Syndrome. So this was Parsonage-Turner Syndrome. Here's this is a patient who had increasing shoulder pain for 2 weeks after an upper respiratory illness. What?
I'm so hypochondriac now. I'm
Okay. And then now, so Susie just got Parsonage-Turner Syndrome. So here we can see edema within the infraspinatus, edema in the supraspinatus muscles. This was also Parsonage-Turner Syndrome. Yeah. And then here we can see a case. This is from Dr. Su in South Korea, also showing now the supra and infraspinatus muscles are the most commonly involved with this. It's an inflammatory condition of the muscles, but any muscles around the shoulder can have it. And it primarily presents as pain, increasing over several weeks, kind of insidiously, and then it usually goes away over several weeks with complete recovery. They thought this was nerve entrapment, just like Susie thought it was with Parsons-Turner. So what is it? It's thought to be neuritis involving the brachial nerves, and therefore, depending upon which nerves involved and how far proximally in the nerve system, it determines which muscles are involved. It originally has been associated with viral syndromes, so I thought it could be either from the virus itself or an autoimmune reaction to the virus. It tends to be unilateral rather than bilateral, so it's still not very well understood. Onset, here it's onset, most common distribution in the suprascapular nerve. MR is important at excluding other possibilities. Okay, Sheila, what do you think of this case?
Okay, so it looks like here we have in the abnormal signal within the brachial plexus, like in the roots coming out, I mean in the, what is this, roots coming out from like maybe C5, C6, heading into the muscles. So likely it's a neuritis. Maybe this patient had a viral infection. So it looks like there's that abnormal signal. It's likely a neuritis in the brachial plexus.
Okay, here you can see the triceps.
And also,
yeah, go ahead.
With right triceps atrophy. Yeah, so maybe we don't, I mean, the muscles look atrophied because there's all a fat. I mean, I see the fat around the brachial plexus, yeah, but that's asymmetric neuritis.
Yeah. So this was another case. This was a case of brachial neuritis. Probably similar pathophysiology to Parsons-Turner syndrome. Again, most of these tend to spontaneously recover, and they may or may not be associated with viral syndromes. Now, here's
so if we in the case of the Parsonage-Turner, maybe if we had imaged the brachial plexus, that's what we'd be seeing, possibly, that kind of thing?
Generally not. You can certainly do it, and maybe with higher quality imaging now, if you have thinner cuts using PD-FAT-SET or STIR images, maybe we could pick this up using MR neurography In the early days, we weren't able to see that, but we didn't have the high enough resolution studies probably to see it well.
What was that then we were seeing? Was that not just a...
That did not present with the classic presentation of Parsonage-Turner Syndrome, because this was more long-standing atrophy, and the primary thing that you'd have to worry about there would be a traumatic root avulsion, which we'll talk about in the cervical spine, producing denervation of the muscle. Parsonage-Turner usually presents with onset of pain, and this was more of a chronic weakness and atrophy of the muscle.
Were we seeing the muscle? Were we on that second case? Was that muscle atrophy, or was it a engorged edematous nerve?
There were edematous nerves. Okay. And here's the case. It'd be nice if this was bilateral, but Jim Linklater from Australia just sent it unilateral. It's hard to see this really, but if you look carefully here, this isn't the normal configuration of the scapula. It's actually rotated up, and this is something called the wing scapula, which is usually due to a denervation or an injury to the nerve that goes into one or more of the scapular, the long thoracic nerve. And again, it can be due to trauma, or you can also see this if you have a lot of fatigue. You can see this sometimes in athletes, especially people who use one arm like a baseball pitcher. Afterwards, they can get abnormal motion of the scapula due to just muscle fatigue. And also, due to repetitive throwing, sometimes you can damage the nerve in that process, and you can lose proper control over the scapula, and that can lead to abnormal mechanics. So it's something that has to be looked at. I don't think MR is the way to make the diagnosis, but this is one that Dr. Linklater was able to see, and this is presumably viral neuritis. But most of the ones that we see were probably going to be due to repetitive trauma. Okay, see who's next.
Which muscle is affected? Susie? What? Serratus anterior.
Oh, no, he's talking about the wing scapula. He's on the previous case.
I'm sorry.
Yeah, that's right. Okay. Right. Let me see. Yuri, what do you think of this case?
Okay, so we got a sagittal and a oblique coronal MRI. There's abnormal signal intensity within the supraspinatus and infraspinatus, as well as to a lesser degree within the subscap. Findings are suggestive of atrophy, atrophic changes. Given that all the teres minor is also involved, so given the fact that all muscles of the rotator cuff are involved, I suspect some kind of a neuritis that would affect all the innervated muscles. So probably either a generalized deinnervation or brachial plexus neuropathy.
Well, I agree with you that all the muscles are atrophic, and that's just probably because of just lack of use in this individual patient. But what's most striking here, I think, is that there's marked fatty atrophy, primarily, much more severely in the teres minor than any of the others. And we can see the big streaks of fat within it, which are clearly different than in the infraspinatus, though I think they're all a little bit atrophic, but it's clearly much more the teres minor, and that's atrophy. And what are you concerned about when you see focal atrophy to the teres minor?
Yeah, axillary nerve innervation, and I would also want to see the deltoid muscle as well. But that is, teres minor is innervated by axillary nerve, so maybe quadrilateral space syndrome.
Okay. So here we can see part of the deltoid. The part that we see looks okay, And down here is the quadrilateral space or quadrangular space, depending upon which anatomy text you look at. And right, the supra and infraspinatus are innervated by the suprascapular nerve, whereas the teres minor is actually innervated by a different nerve that goes through the quadrilateral space. And we can just, I don't think we need to spend a lot of time going through the nerves here, but we can see this is the area of the quadrilateral space where the nerves come out here and innervate the teres minor. So continuing this theme, here we can see a case of a paralabral cyst, which is coming across here from a posterior labral tear and extending, let's see, Sheila, what space is it going into here?
Spinal glenoid?
Yes, spinal glenoid notch. Actually, I meant to say Susie. Too bad. What else do you see here, Sheila, in this particular patient?
So it looks like there might be atrophy of the infraspinatus muscle.
Yeah.
There are degenerative changes of the glenoid, but I think that's spinal glenoid is an tear. So.
And there on the PD fat side of the
impinging on that.
coronal, you can actually see the abnormal signal within the muscle. So there are a number of places where you can get entrapments. We've just been talking about three of them, really: the supraglenoid notch, the spinal glenoid notch, and then the quadrilateral space in between, affecting different nerves. And we've already talked about the suprascapular notch, getting both the supra and infraspinatus. Spinal glenoid notch is more distal, and it just primarily involves the infraspinatus. But now with MR, we can actually see where it's occurring, so we can actually see where the cyst is, and then it's nice to see the muscles. But most of the time, when you have a cyst in those locations, it actually doesn't produce any definable changes within the muscles, right? But occasionally it does. And certainly when it does, you have to think more in terms of the need for treatment than when it doesn't. Okay, Susie?
So this shows complete atrophy of the teres minor muscle. Okay, almost complete atrophy of the teres minor muscle. So again, one would be concerned about axillary nerve damage.
That's the other side.
That's the other side. Huh. And there the teres minor muscle looks normal on the right.
So what's happening?
So obviously it's a unilateral process. I didn't even see that. Oh my God. I think I should quit right now. Oh my God.
And it's kind of a corner shot, so it would be easy to miss just on the shoulder images, but there's this huge lipoma which is stretching the nerves that go through the quadrilateral space there.
That's the tricep that's pushing out a little bit?
Let's see, yeah, I think so too. So this is the area in Granson and that atlas, I think it's called the quadrangular space, but it's this space right here, teres minor above, latissimus dorsi here, triceps there, so that was the triceps that was pushing away. Teres major is coming across there, and it's this little triangle here where the vessels and the nerve goes. And there's the recurrent nerve that goes back and innervates the teres minor muscle. Michael, what do you think of this case?
Sagittal and coronal views. And the sagittal view looks like the teres minor muscle is atrophied with increased signal. Then on the coronal view, looks like there's a large osteophyte that's arising from the humerus there that's impinging upon the quadrilateral space on that image there.
I'm sorry, I just had to check. What did you say was impinging on it?
I think it's a large osteophyte.
Yeah. So, by the way, Sheila, I sent you a link earlier. I just realized that you sent me a text message, but I'm glad you found one anyway.
Yeah, sorry I was late.
Yeah.
I couldn't find.
So this is a 51-year-old male, and what we see here is just a large. Now it's very common to see large marginal osteophytes and degenerative disease. It's fairly uncommon, but these can be large enough where they compress the nerve down here and cause atrophy of the teres minor. And this is a kind of an interesting review in skeletal radiology where they talk about a lot of different tunnels around the body. This being one, the suprascapular and spinal glenoid notches, the carpal tunnel syndrome, the cubital tunnel, and so forth. So just areas where you can get compression of nerves commonly leading to symptoms. And then this is just, here's just a little bit talking from Dr. Su about compression of the axillary nerve in the region of the quadrilateral space. Okay, Aram, what do you think of this?
Markedly increased signal in the pec major muscle on the left. Looks like it's involving only one of the heads of the muscle. So once again, I mean, this could certainly be secondary to a muscle strain, but I guess we would have to consider a nerve impingement as well. Delayed onset muscle.
So what's delayed onset muscle soreness?
It's actually something, I guess it's fairly common in weightlifters. 2 days after lifting, you could get a diffuse reactive edema in the muscle, which resolves.
Yeah, it's very common. Anyone who really works out hard in a muscle that's not used to that will get soreness. Now you can get soreness immediately, and if you get soreness immediately, you have to be concerned more about a tear to the muscle or a muscle strain. But a common phenomenon below that level is that you're fine that day, and then it starts getting sore the next day, and usually peaks at 48 hours. Though in more severe examples, sometimes it can last for much longer than that. And usually by 72 hours, the muscle soreness goes away. And it's called delayed onset muscle soreness syndrome. It's basically everyone who does weightlifting or exercise is familiar with this phenomenon.
I get that problem every time I wake up in the morning.
What's interesting with this phenomena, at least clinically or from personal, I think it's when you haven't worked out a muscle set, or wherever you haven't jogged in a while, and then you go for a jogging. Yeah, you go for that first big jog. 2 days later, you're like crippled. But then, like if you keep jogging, then you don't have it anymore.
That's known as conditioning.
Conditioning. Now, but if you really overuse a muscle, even if you're conditioned to a certain level, if you significantly go above that level, you can still get it again. Yeah. It all depends upon the level of conditioning of the muscle. Right.
Any physiology behind it? Do we feel like we understand it at all, or is it just
I don't know I don't really know exactly what's happening on the cellular level, though. If you look at the kind of if you actually look at it under a microscope, you actually get microscopic disruptions of where the fibers connect with one another. So I'm pretty sure it is actually due to microscopic tears within the fiber elements, and then they heal pretty readily after that. So I think it's a microscopic tear phenomenon. And if you do it too much, then you'll develop a muscle strain, and if you do more than that, you'll actually get a rupture and if you affect one of the blood vessels when that happens, then you can get a hematoma in that location. And each of those are progressively worse, taking longer to heal.
It's probably more on the interstitial level where there's really no permanent any kind of cellular damage. It's just you get edema due to osmotic whatever. I don't remember any of that anymore in the physiology. But I think these are very self-limited problems.
Yeah, under the microscope.
Walk before you run.
Under the microscope, there is kind of, I think it's called a Z line. I forgot the exact name for it, but where the mouth, the fibers actually connect with each other, there is a line there that's well described in the histology world, and I know that is disrupted if you do biopsies on these individuals. So it really is kind of an interstitial micro tear, I think, of the fibers. Okay, let's see, Susie?
I see you have several arrows on the left and right hand side. I'm not okay. I'm not 100% sure what you're pointing to there, although there is abnormal signal intensity within. Yeah, there's abnormal signal intensity within the muscle and a little sliver of fluid collection. Just on this alone, I'm sorry to say, I don't know if is it the
That's the scapula.
scapula. Oh.
So what we're seeing here is edema between the superior part of the scapula and the rib cage.
So again, it's probably that short term. Oh no, I guess not.
So it's really a bursitis due to overuse and damage to that area, and you could probably get some micro tearing again and inflammatory changes. But this can be painful. Remember, the shoulder is really a number of different joints. You've got the AC joint, you've got the glenohumeral joint, and you've got the scapulothoracic joint. And they're all very important. We tend to forget about the scapulothoracic joint, but for normal motion of the shoulder, the motion of the scapula is very important. And when you get lectures with Curl and Job concerning the physical therapy of the shoulder and how to evaluate it and so forth, the physical therapists are very concerned about motion of the scapula, and they'll go through how that's evaluated. And it's not always easy because the motion of the scapula is very complex motion because it's basically floating on a plane, and it's really a 3D motion more so than any other joint.
Well, most people cannot abduct past 90 degrees without scapulothoracic motion. So that's at 90 degrees of abduction, your scapulothoracic joint starts to move. Otherwise, you cannot abduct any further. And a lot of people, like I started early on telling you guys, there are loosers and stiffers, and everybody's different. So there's a large normal range for people.
Right. So any questions? I think this will end our discussion of the shoulder until we start to talk about shoulder masses later in the winter. Okay.
Dr. Cruz, I have a quick question.
Sure.
On adhesive capsulitis, if you do see thickening more than 4 millimeters of synovial capsular thickening in the axillary pouch, what do you say in your dictation? What is typically your comment?
What I use is if there is edema around it with irregular, indistinct margins on the PD FATSAT images, then I say that there's thickening with edema, and this raises the question of either trauma or capsulitis. But if it's just like 4 millimeters thickened, I'll kind of describe it in the body of the report and kind of leave it, because I've generally found that the thickness of the axillary recess is very variable, and generally when it's thickened without any edema, which is most of the time, it doesn't really it's not clinically important. I would certainly look at the area of the rotator cuff interval, and if you see changes there, then I would talk about capsulitis. If it's markedly thickened over 6 to 8, then you have to describe it and raise the question of fibrosis or chronic capsulitis.
Okay. Thank you.
Okay. All right. Thanks, everybody.
Just real quick.
Thank you.
Thank you.
If the axillary pouch is thickened, but there's nothing going on in the rotator interval, then just forget about it. It's not.
I would describe it, but in my experience, that ends up not being clinically relevant.